So I think one of the main things to think about is what we're not, because I think that's just as important as what we are and what we do. So we're not here to treat mental health conditions, and lots of people think we're an extension of an LMHT, or that we have those similar resources, and we don't. So we are here to signpost people to LMHTs, to third sector organisations if that's needed. And we aren't able to accept the clients on the list below. So those people who are experiencing severe mental ill health, they really do need to go to the local mental health services or crisis, dependent on what their need is. Those people who are at risk to their self or others. And when I say that, we do have clients who are a risk to themselves or others, but it needs to be around their neurodevelopmental needs rather than their mental health needs. Those people who are undergoing assessment or treatment for psychosis, those people that require care coordination, we don't care coordinate, and we don't do that because we don't have the infrastructure. We're a Monday to Friday, 9 to 5 service, so we don't offer any out of hours support to people. So if they require care coordination, they need to be with the local mental health services. Those people who have a suspected or confirmed diagnosis of intellectual disability, they go to the IDD service. We don't accept self-referrals. You can imagine if we did, we'd be inundated even more than we actually are. And we don't accept third sector referrals. Also, those people who are requesting ADHD medication but don't have any evidence of their diagnosis. We do offer a lot of consultation and liaison into services where appropriate, particularly for those people who need additional support around their neurodevelopmental conditions. But largely, these are dealt with in adult mental health services. Next slide, please.
I'm just going to pause because Kerry's got her hand up. So do you want to ask your question?
Oh, sorry, Kerry? I can't see that. It's got my
camera.
All right,
that's
here.
right.
Go on, Kerry.
Just a quickie, yeah. Regarding the unacceptable, not unacceptable referrals, but the unaccepted referrals, would you accept a referral for someone that's a past or present drug user, has been self-medicating with something like amphetamine because they feel they've got ADHD?
We get loads of those, loads and loads of those referrals, and it really is individual. So it's dependent on what, well, the nature of whatever they're using, how regularly they're using it, whether they want additional support to actually reduce that use. Because sometimes when you treat the ADHD with ADHD medication, they can reduce their medication, their drugs, because they're self-medicating with that. So it really is a balance in terms of what we do, and we just sort of consider safety, you know, from a sort of safety perspective, what's safe for the client. But yeah, we do get a lot of referrals for those people who are self-medicating on all kinds of different street drugs.
Okay, thank you. It does make sense.
We just have to ask them not to have taken anything before on the day of the assessment, so we can get a proper assessment done.
Yes,
I know a lot of people say no to lots of other medication and help because they need to deal with the drug addiction first, which I kind of understand. But then when people come back and say yes, but the problem is I think I have blah blah blah. People have said to me they think I have. I've been self-medicating, I think, for this reason. I have tried to stop. And when I do, my life just becomes blur. They feel quite normal, not even high actually on any kind of amphetamine. And it's kind of quite interesting because, of course, I don't know these people very well, but I can only go. And I thought, I wonder.
Are you going to mute? Your mic's gone mute.
Sorry, I don't know what I did there. So yeah, I'm just saying I don't know these people, but of course what they're telling me is they have been self-medicating, and I suppose having that self-medicating, when they tell me that if they don't, they're not normal, but they say they're not high when they take it, it just equals them, levels them out. And I'm like, oh, but I always think that if I referred someone or told them to refer, because obviously the referral process is quite long, I always think that they'll probably be turned down. But actually that's really useful information to know that, because then I can say, actually, yes, just be honest, because I think they're a bit afraid of being honest in case they get the referral decline because of that. But that's really good to hear. Thank you.
Yeah, it's really important when they come, if they're referred for a diagnostic assessment, then obviously they can't have been using on that day.
Yeah.
And we do a test called a QB test as well for ADHD, and they need to have not used on that day. But if they're really honest with us at their initial screening appointment, then we'll be able to navigate that with them and obviously signpost or advise accordingly.
Thank you for that.
So we are quite a large team now. Kerry will remember us from many years ago. I think there were about 6 of us when we originally started, which is when she had a placement with us. But now we've got quite a large team. We've got a service manager. We've got 2.1 consultant psychiatrists, 4 clinical psychologists, a CAP apprentice, an assistant and a trainee psychologist, 2.5 speech and language therapists, although at the moment, due to maternity leave, etc., we've got half a one, I do believe, who's very busy. 1.6 OTs, and Julia is obviously one of those. 7 nurses, including 1 being myself, and 2 nurse apprentices, and a large business administration team. So we're a lot bigger than we were, although saying that, we need to be much bigger in order to manage the number of referrals that we receive. So when you're completing the referral form, and we get a lot of queries about the referral form and the fact that it's long and it looks more complicated than it actually is. But if you're referring for neurodevelopmental support, for example, you only need to complete Part A. It is quite clear on the form which parts you need to complete, but I think it can be a little bit daunting when you first sort of open it. The client can complete Part B, which if that can be really helpful, particularly for GPs, if the referrer is unable to do that, if they don't have the time to do that. The important thing is what's included, really. So we need to see examples of significant impairment associated with possible ASD or ADHD. We get a huge number of forms that just say fidgety as a child or doesn't like change, which is absolutely true, but we do need much more than that in terms of significant impairment. We need to see that these difficulties have been present since childhood, pre-12. So lots of people have significant trauma in their life, for example, or lots of mental health issues, but there is no evidence of impairment of neurodevelopmental conditions pre-12. So we need to see those examples of significant distress associated with those neurodevelopmental difficulties in specific areas of their life. And the screening questionnaires do need to be completed. It's really difficult for us to sort of screen half a referral and obviously have to decline those referrals until we get the additional information. And it's so important to make sure that we have all the right information on that form as much as possible, because that's all we've got. That's all we've got to go on in terms of that referral. And we don't want people going round and round in circles. So the more information that can go on there, the better. And a kind of important thing to consider is that neurodevelopmental conditions are lifelong. They don't start later in life. So if somebody's presenting to you and they are saying, my issues started when I was 24, then the chances of them having a neurodevelopmental condition are less. Next slide, please. So as I've said, please send past assessment letters, supporting evidence and information, evidence of past treatment. Just, send as much information as you've got attached to the referral form. We do consider private diagnostic assessment reports, both for ASD, but largely for ADHD, where people have had a private diagnostic assessment and they are seeking treatment, NHS treatment, continued or titration. I would say that these diagnostic reports vary in quality. And so we often have difficulty understanding how this diagnosis was reached, and we have to go and seek further information from that. Also, some people's diagnostic remit is not actual treatment or intervention for the condition that they've diagnosed. So that might be, for example, an educational psychology report, which we can't accept as a form of evidence of diagnosis, because the issues that they're considering are largely related to their learning rather than their developmental history, physical or psychiatric history. And we require those in terms of having a formal diagnosis. So some people do have to go through further assessment before we can offer any treatment or interventions. And we benchmark all those assessments that come into us and all those criteria against DSM-5 and the NICE guidance. Next slide, please. So people wait a long time on our waiting list. I think the important thing to think about is that although it says approximately 36 months, which sounds incredibly long, and it's not really where we want to be. If we look at other services across the country, they're equivalent to us, or actually some places have got a 7 to 10 year waiting list for a neurodevelopmental assessment, just due to the number of referrals. So in terms of ADHD treatment, you're looking at a lot less a wait. At the moment, it stands at 4 to 6 months. It's usually around 4, but because of the really awful medication shortages that we've experienced since last October, things have been delayed quite significantly in terms of treatment, because there's been no availability of ADHD medication for quite some time. OT intervention, 9 to 12 months, same with speech and language therapy. Post-diagnostic support between 6 and 9 months. We can put people onto the recovery college course as well once they're diagnosed, as part of their post-diagnostic support offer. The medication pathway is around 6 months for titration. It does vary dependent on the individual, but normally we can do that in about 6 month period. We do offer waiting well calls, so we do those frequently, or as frequently as we can, and we are currently reviewing that process at the moment. There is a post-diagnostic, pre and post-diagnostic support service, which we'll talk about in a little while. We send out an acceptance letter and a waiting well leaflet. It's got lots of information and signposting on there, which people find really helpful. And clients are not contacted until they reach the top of our waiting list. An appointment is arranged if it's still wanted. Some people have moved out of area. Some people no longer want their assessment. So at the moment, we are receiving 500 referrals a month, which is absolutely huge. And we are not in any way commissioned for 500 referrals a month. We're commissioned for 500 referrals a year, and 90% of those are for assessment. So we are absolutely inundated with referrals at the moment. This is the pre-diagnostic, mid-diagnostic and post-diagnostic support service. It's really, really helpful. We had a presentation from them not so long ago, and they were saying that a lot of people do not self-refer to this service. They can self-refer, but they don't. So it's really important to get their consent to refer if you want to refer to them. But they do offer a very wide range of support. So they offer peer support, they have a forum, they offer workshops looking at filling in your PIP form or looking at reasonable adjustments for work. They do signposting for things like finance, housing, work, all of those things that people find quite problematic to navigate through. And they have some community engagement as well, such as walks and litter picking and all of those sorts of things. So really helpful for a client whilst they're waiting for their diagnostic assessment and beyond. And they are on social media, so there's some signposting for you there if you want to have a look at that service, but they are very helpful. Next slide, please. Okay. So once we receive that referral, we screen referrals on a daily basis. So we have a daily SPA that that screens all referrals. They're screened on an MDT basis, so that people don't wait lengthy periods of time to find out the outcome of their referral. Once we've done that, there will be an initial assessment or interview with the client. Then they will be offered their diagnostic assessment when they reach the top of the referral list. They'll be sent questionnaires, psychometric tests, and then given feedback of the outcome of their assessment. If they require any additional testing, then we will organise that. But the diagnostic assessment is the DIVA, ADIR, face-to-face. We do some stuff over Teams, if possible, for informant interviews, or over the phone, if need be. But the actual face-to-face part of the assessment is done in clinic. And I think the important thing really is to think that a person doesn't need a diagnosis to have reasonable adjustments or to get services to meet their needs. I think it's so important in that interim period to look at what the needs of the individual are. We hear really often that I can't get any help because I haven't got a diagnosis, but you don't actually need a formal diagnosis to get the help that you need. So once you've had your assessment and we've concluded that, the client and the referrer and GP will get a full report, which is quite lengthy, and we'll agree any future care planning as appropriate and signpost for any onward referrals or offer some short-term psychoeducation to the individual. So some of the key sort of things or words that you might see, so things like neurodiversity. So this is about the range of diversity across the population as a whole, and just thinking about, the fact that everyone's brain works differently. And I'm sure that a lot of us can associate with the term neurodiversity. So neurotypicals are the majority of us, and they're seen as the social norm. So those people who don't have a neurodevelopmental condition. And neurodivergent, so this is the minority group, seen as different to the norm, not a mental health condition, but within that, lots and lots of other conditions are often there, such as stress and anxiety and all of those sorts of things. But lots of our clients will describe themselves as neurodivergent. Next. So thinking about how many people are we dealing with, and I think we're at the point sort of across the country really thinking about why we medicalise these conditions, why people need to go through those diagnostic assessments, and can people just decide that they're neurodivergent because there's so many of these people in the general population. So 15 to 20% of people, or greater than 1 in 7, are neurodivergent, and I would suggest that that's an underestimation of the number of people in the country that are. So that's around 700,000 people, or 1% of the people in the UK are autistic, which is quite a lot, and 2.6 million, which is much more common, or more than 3% have adult ADHD. But if you sort of compare that to things like dyspraxia, so at least 1 in 17, or over 6 million people have dyspraxia, and that's from the Dyspraxia Foundation in 2023, just meaning that they think, behave and process, interpret information in a different way to other people. We don't know what causes neurodevelopmental conditions. It's really unclear. We don't know whether about the genetic or environmental considerations. There's lots and lots of research going on, but nobody has managed to sort of pinpoint anything concrete at this moment in time. But we do know that it's not about someone's upbringing or life experiences, that people cross all social boundaries in terms of having a neurodevelopmental condition. And next. So I won't go into huge detail because I'm aware of the time, and Julia's got a significant number of slides to go, but there are lots of different types of neurodevelopmental conditions which impact on functioning across the board, their learning, social ability and attention. They can all overlap, so somebody can come to us with 4 or 5 of these different conditions. And what we do know is that executive function, so the ability to plan, sequence, coordinate, is affected in all of these conditions. And I will hand over to Julia.
Thank you, Jackie. So for this part of the presentation, I'm just going to be talking to you about the 2 main ones that we would assess for and diagnose, which are going to be ADHD and autism. So obviously, as Jackie's already said, ADHD is a lifelong condition, so it's got to have started in early childhood, and we're seeing around 2.5% of the general adult population with the condition across both men and women. But I think it is more or it was more diagnosed in males because it was more obvious in them, but we are getting a lot more women coming for diagnostic assessments now. But the type of ADHD that they might be diagnosed with might be slightly different, so we'll go into that a little bit more. But the overall core symptoms of ADHD would include inattention. So examples on the referral form that we would need to be looking for might include things like poor attention or poor listening and filtering, being forgetful and disorganised. Includes things like hyperactivity, maybe lots of movements and fidgeting, restlessness, being on the go either physically or mentally, rushing and then making mistakes, and being impulsive as well, so maybe blurting things out, not having that filter, being able to bite the tongue or interrupting others and being unable to wait. And these features are usually very impairing even for people that might appear to be very high achievers, so it doesn't matter in terms of intellect, it can still be that the person has ADHD regardless of where their intellect lies. And can impact on various different features, so their education, their employment and the relationships as well. And there might be other, like we've said, co-occurring conditions, so potentially some tic features or even full-on Tourette syndrome, possibly autism and things. And there's also a high morbidity with other mental ill health as well, or personality disorders, or like we've said about substance misuse, we see that a lot as a co-occurring feature of ADHD, and offending behaviours, but it's highly treatable as well. So that's the benefit of getting a diagnosis of ADHD. We need to see that symptoms have been present in at least 2 settings as well. So like maybe at home and at school, or home and work, so that we can rule out the possibility that it's due to one certain area that the person is functioning in as being the cause of the difficulties. And around 65% of people that are diagnosed in childhood retain some impairment in adulthood as well. We see probably 5% of the children that are diagnosed in the children's population, and 3 to 4% in the adulthood population. So talked about figures really already. So this is just breaking down inattention and just some examples that would be really useful to include if the person can think of things that might relate to potential inattention, and really being clear on the form about the childhood examples versus the current examples, and not just a bullet pointed list, just actually describing the difficulties with their attention, and being able to listen or follow through instructions or organise themselves, or engaging in tasks that require sustained mental effort. Might be losing things quite a lot, whether it's their personal belongings or different things, or easily distracted by different things going on in their environment. The forgetfulness is often because of being overloaded as well, as opposed to cognitive decline. So area of difference there. And then with the hyperactivity aspect of ADHD, we might see these types of examples. So lots of fidgeting, getting up to leave the seat when it's not appropriate to do that, say in lectures, or running and climbing about, or in adulthood it might just be that they've got this strong feeling of internal restlessness because the actual physical restlessness might have subsided a little bit, or difficulty engaging in leisure activities quietly, being on the go, or feeling as though they're driven by a motor, and they might be talking excessively as well, or making careless mistakes because of the hyperactive or impulsive features. Might be blurting out answers before the question has even been finished being asked, or they might have a tendency to say what comes to the mind without considering the timing or the appropriateness of what they're saying. Difficulty waiting their turn, or difficulty waiting for others to finish tasks at their own pace, or being extremely irritated if they're having to queue, or interrupting and intruding on others. So it might be difficult for them to watch others struggling with a task without jumping in to try and do it themselves because of that impulsive urge. So in terms of getting a diagnosis, you've got to have a minimum of 5 symptoms of inattention, hyperactivity or impulsivity, and been displaying the symptoms for at least 6 months continuously. And they've got to have started before age 12 in 2 different settings, and they've got to be causing some functional impairment within the different life areas, and you've got to have considered whether those symptoms could be better accounted for by another condition that might be going on, because obviously there would be overlaps with other things as well. So in terms of the subtypes, once you've been diagnosed, you might be diagnosed with predominantly inattentive type, which is usually more common in females, where the issues are more around memory and inattention, or predominantly hyperactive type, which is more common in males, where it's mainly hyperactive or impulsive features, or the combined type. So you've got to have had 5 features or more within each of the different inattentiveness, hyperactivity and impulsivity. So they might still have features of the other categories, but just not enough for a combined diagnosis. So they'll be given one of the first 2. And we might say, well, that sounds similar to me, aren't these just human characteristics? Because we all do those sorts of things. But usually in ADHD there's a big difference in terms of how chronic the problems are and how much they're impacting functioning. Having some of these features doesn't definitely mean that they've got ADHD as well. So it's just breaking down and thinking about the level of severity, or how extreme and how intense they experience those symptoms. Like, are they just losing the concentration for a little bit, or for much of lots of meetings that they're in? Are they forgetting the task a little bit at the time, or getting a bit distracted in conversation, versus just really struggling to focus in any conversations, having massive impacts? And then we're thinking about persistence. So has it always been the same throughout life? How often is it happening for them? Are they just losing the odd thing here and there day to day, or is it causing significant difficulties? And pervasiveness, in terms of that, we're thinking about the different situations. So how much is it interfering across different settings, and impairment from the symptoms? So are they struggling to complete and finish tasks daily at home or in the family, with the self-care routines or chores? Or are they experiencing the impairments across work and education, as well as relationships as well with friends, etc.? So we've talked a bit about executive functioning. So this is it broken down really. So it's an umbrella term for a group of skills that are usually used together, and they help us to be able to execute and carry out our day-to-day tasks. And we use a few at a time. So when there's difficulties with executive functions, some of these difficulties can be viewed as that the person's being lazy or lacking motivation, but it's not usually the case. It's because those difficulties are impacting on them, and they start in the prefrontal cortex of the brain. So it's where that brain hasn't potentially had chance to develop so well, and they might have to have more time spent on learning those skills and being taught how to manage those different areas. And it is common across the neurodevelopmental conditions, so in ADHD and autism. So it includes, obviously, with activation, how are they with organising and prioritising their work? How are they with focusing on tasks and moving their focus from one task to another, and dealing with distractions in the environment and continuing the focus? How are they with effort and putting in the right effort across the duration of the task? Is it consistent effort? Is it affecting processing speed and ability to focus throughout? And what about managing their emotions? Are they struggling with modulating those emotions, which might impact on them even being able to want to choose to do the task in the first place? And is their short or long-term memory affecting things in terms of dealing with daily tasks, and also action as well, so in terms of monitoring and regulating their actions and behaving appropriately and thinking beforehand of consequences and restraining impulses. So these are some additional issues that we might see in ADHD. Again, it's not something that's definitely going to be co-occurring, but there is a high prevalence of difficulties in these areas, and I think we've covered a lot of these already, just looking down. We might see some overlap with personality disorders as well. Sleep disorders is a common feature in ADHD, that difficulty with being able to turn the brain off and close it down and thinking about helpful things for nighttime routines and what might need to change to promote better sleep. And sometimes we see offending behaviour as an overlapping co-occurrence as well. And obviously, the person isn't obliged to take the medications, the treatment option for ADHD. They might prefer non-pharmacological interventions, but our role is to provide them with information to allow them to make an informed choice about whether they want to try different medications, and what that could mean for them. So these are a few of the medications. It's a bit more Jackie's domain, so I don't know if she wants to come in here and say a bit about this. But I guess there's some that aren't on there as well that you might consider prescribing to.
Yeah, there's quite a few on there. So I mean, basically the situation is we have stimulants and non-stimulants. So always take the sort of first line stimulant treatment. At the moment, it's incredibly difficult because a lot of these brands are not available to us due to the medication shortages. So we're having to prescribe generically. But basically, we go down the stimulant route initially, and then the non-stimulant route if absolutely necessary. Atomoxetine, methylphenidates, and dexamphetamine are all on the shared care protocol, but guanfacine isn't. So anybody who is on guanfacine will need to remain within our care.
Here's just some of the possible side effects that some people might experience with the different medications as well. But again, maybe something you might want to look at later on.
Yeah.
Just a question on the medication. So who would normally manage it onwards? So would it be, I appreciate you said one medication remains under your care. Would the GP have to monitor to therapeutic dose, or would you ensure they're at a therapeutic dose before be discharged?
Yeah, no. So GPs can't initiate, titrate, or make any changes to the medications. They're all amber 2 medications, apart from guanfacine, which is red. So we would initiate, titrate, and ensure stability. So optimize their treatment, which can vary in terms of length of time that takes. For some people, particularly if they have autism as well, it can be a lot slower. So we get them to the optimum dose where the patient's reporting good effect from their medication. Sometimes we go up and down the whole medication availability before somebody settles. Once they're settled, we then put a shared care agreement in place with the GP. The GP sees them at 6 months, and then we call them back for their annual review at a year, and that continues whilst they're on that medication. But if they need any changes or they're experiencing any side effects, GPs will contact us directly during the interim period.
Thank you.
Thanks. So in terms of the non-pharmacological interventions, there's different things that we can support with and offer within our service. And one of those is the Living Well with ADHD course, which is a 6-week course. We have booklets that we can share and that are also available online to help them understand the condition. And there's also a short film on YouTube and support from additional services. So one of the things that's not on here is there's an adult ADHD support group in Nottingham that's held every month. And there's a couple of websites where they can get a bit more information about ADHD there. So just moving on to autism, I'm just aware of the time, we've not got a huge amount of time left, but in terms of autism, so usually we're looking for two particular key areas of dysfunction within the DSM-5, which are deficits in the social communication and social interaction across multiple contexts, and restricted and repetitive patterns of behaviour, interests and activities. And as part of that, now we're including sensory impairments now that are considered in the diagnostic criteria, and that potentially is also going to be hopefully in the future as part of the ADHD criteria too, because we are seeing a heck of a lot of overlap with sensory impairments in ADHD as well, even when autism isn't present. So symptoms must be present from the early developmental period as well. And we usually use the word autism as opposed to Asperger's. It's usually the preferred term to say a person's autistic. And these are some of the areas that we're going to be looking at just in a little bit more detail. But it does affect people in different ways, so you'll never get two autistic people that present in the same way. But they do have to have certain difficulties within those two certain areas that was on the previous slide. In terms of these cognitive differences here, we're thinking of things like theory of mind, so they might have difficulty understanding what others might be thinking or feeling, and that can make social interactions very difficult or confusing or unpredictable. And they also might have difficulty with what's called central coherence, which is where the brain actually looks the same structurally, but differences are in how information is processed within the brain. So it might be like an attention tunnel or processing one thing at a time, and struggles with focusing on the bigger picture because they're focusing on the detail instead, which can come with a lot of benefits and strengths, but they might struggle with it, establishing meaning from lots of information, and that can impact on their sensory perceptions as well, and in social situations. In terms of ability, it does extend across the intellectual ability range. You might have a person who's autistic with a learning disability. Our service assesses and diagnoses autism without learning disability as well. So obviously there's a separate team, the Intellectual and Developmental Disability Service. Savants are rare. I think in the media it's often portrayed that if you're autistic, you've got some sort of special skill or other. We do see it, but it's not a common thing. But what is common is adaptive impairments within daily living skills and impaired executive functioning. So in terms of breaking down the social communication interaction, so on the referral form, we're thinking of giving us examples from childhood and adulthood in these certain areas. So in terms of understanding others, or making themselves understood, they might appear, insensitive or socially inappropriate and not meaning to be. And it's about how often they're misunderstanding others and how they relate to others, how their relationships are made and kept throughout their life. So they might have strong desires to have relationships, but struggle to actually make and keep them. Many autistic people also have and find relationships that are well suited to them. So it's just all dependent on the person. They might have struggled with thinking and interpreting literally. So things like jokes and sarcasm, or metaphors like it's a piece of cake or it costs an arm and a leg, that sort of thing. You might wonder what all that means and take it a bit more literally because of that difficulty with flexible thinking. And that might mean that small talk can be difficult, or problem solving, considering other people's viewpoints and relating to others, or managing changes in conversation, like if the topic changes, and the processing speed required to keep up with that and move the mind onto that next type of topic of conversation. And then also considering the non-verbal differences as well, so things like struggles with eye contact or gesture, facial expressions, tone of voice and personal space, but also understanding that obviously there's differences in different cultures as well, so whether those things are could be down to that as well. Differences in the use of language, so we might see in autism there might be some echolali or copied speech, or we might see repetitive speech or idiosyncratic or stereotyped speech. So it might be things that people say a lot that aren't used as flexibly by an autistic person, or idiosyncratic is where that people don't usually use that type of phrase to describe something. They might say I instead of you, so reversing the pronouns. or they might make up words as well, which are called neologisms. They might have very good language, expressive language, but find it hard to understand expectations of others and some social rules, so like turn taking, and reciprocity, and knowing if the other person's getting bored or irritated, and understanding, reading the emotions or feelings of others and what their intentions might be. And all that can impact on their self-esteem and confidence. You know, it might mean that they have increased anxiety or depression, or just feel completely overwhelmed in social situations. But there are helpful things that obviously can be done. So things like giving them extra time to process information, keeping your sentences short, being specific, asking for feedback, you know, respecting each other and each other's different ways of interacting, and asking checking questions to make sure that they've understood. So another one on executive functioning, just to kind of presented a little bit differently. So and how that impacts the autistic person with day-to-day skills. Again, they might be seen as difficult, but often it's due to these executive issues and flexible thinking. So, for example, take the simple task of having breakfast. They need to be able to remember to have it, what's involved to make it, and then juggling other things that capture their attention as well, and being able to focus on the task to filter out the other things in the environment and have continuous attention to be able to do that, and block out things that can wait, and stop themselves from doing other things until after that would get in the way, and then hold the information in the mind whilst attending to something else that they need to come back to. So they might need support in terms of when they manage it or when they're learning day-to-day tasks. Sometimes that support is required long-term by another person. But again, there's various strategies we often recommend in post-diagnostic support sessions that are particular to the person, because not everybody finds the same things helpful. And we'll go through various different things there to help with these different areas of functioning. So we might see sensory differences. So broken down here, the 8 different sensory systems and what sensitivities we might see. And it's obviously a very not exhaustive list, because it can be very wide ranging. But the sensory differences, you know, obviously impact the way that they see the world, and can actually lead to more pleasant feelings and enjoyment from the senses. But also more distress and more anxiety, because of that difficulty in blocking or filtering. You might experience pain from different inputs as well, like hearing or sight. You might see some preoccupation with different aspects of objects. And we might see some stimming behaviours as well, so different things can impact on that. There's just a word about interoception as well, so that's the sense of being able to tell what's happening internally in terms of your body states and your emotions, and that's a common thing in terms of autism, and being able to describe those states and being able to share what might be the matter at primary care services. You know, struggling with describing physical symptoms and things. So it might be a case of ruling things out, or asking very pointed specific questions, or using body maps and that sort of thing, or scales of 1 to 10. So neurodivergent people, they might not be modulating how much sensory information they need. They might then struggle to filter out what's not important, and therefore be overloaded by sensory information, which might lead to different behaviours and experiences, and that might stop them from wanting to access different venues within the community that might not have considered various different sensory impacts. But often what we would do in our service, if sensory needs are a particular issue, is just go through various different strategies that they can try in terms of helping them understand why and what those needs are, and what can be done about them, really. And these are just a list of some of the impacts that we might see because of sensory differences. And then restricted repetitive interest activities, routines or behaviours. So this is the other of the two key areas within the DSM that the person needs to show evidence of to be considered for a diagnosis. So not everybody likes routines, but they can be very helpful for predictability. So you might see a person that likes to eat the same food every day or travel along the same route every day. But we do see a lot of people who have a very strong preference for routines and rituals, and these things can be really fundamental to their well-being and their happiness. And they can actually serve as real strengths for the person as well. But likewise, it can be quite hard for them to cope with changes to routines and things as well. We might see very strong interests. Maybe they collect certain things that are very specific. They might struggle with planning ahead or predicting what might happen next because of lack of flexibility of thought or lack of struggles with imagination and creativity. Adhering to rules might be a big thing of importance for them, and we might see repetitive behaviours as well. But it's not all bad, you know, those strong interests can be channeled into studying or paid work or volunteering or other meaningful activities as well. And often autistic people sort out employees because they're loyal and committed, etc. So in line with some of the repetitive behaviours, you might see some stereotypes or repetitive motor mannerisms, and there's a bit of a list there of what you might see. And those behaviours might help them regulate emotion and process the sensory environment, help them reduce stress or motivate them. So it shouldn't really be stopped unless they're actually causing harm to the person. These are a list of some of the barriers to living with autism or ADHD in terms of the environment being difficult to access, or societies, systems and social rules that are usually geared around neurotypical, and then accessing services might be difficult without reasonable adjustments being made or put in place. And then just considering about communication as well and the person's preferred method of communication. And some ideas for making adaptations here. So providing text reminders, trying online appointments, encouraging them to write things down, keeping appointments short, fidget tools on offer, movement breaks, electronic copies of things, and then thinking about the various different senses and what needs they might have, and just being able to try and keep their environment as low arousal really as possible. Just asking them what would be helpful for you if you know before an appointment that they might be autistic, for example, what would make things easier for you. You don't have to tell anybody that they've got this diagnosis. Not everything works for all people, but you know, adaptations don't need a diagnosis for them to be made. So I've got a list of strengths here in autistic people. You know, humankind relies on the neurodiverse brain. It's not a deficit, but a difference, and there's various unique skills and talents. Not all autistic people consider it a disability, but a difference in how the brain works. And some ADHD strengths as well that are typical that we might see as well. The video you can watch later here. And our contact details for if you've got any questions that might come up after this is all finished and you want to drop us an email, that's fine. We're happy to do that. And that's the end. Finished bang on time, but
That's
hopefully
perfect timing.